Hi, how are you all? This is the Gastroenterology Ambulatory Surgery Clinic performance budget created by Tony Banks and Patricia Tharp. We are DNP students at Arkansas State University. We're about to start our PowerPoint. Hope you like it. Hi, how are you all? This is the Gastroambulatory Surgery Clinic performance budget created by Tony Banks and me, Patricia Tharp. We're students at Arkansas State University DNP. The performance budget for this study investigated the financial statement of a proposed 1.5 yearly budget at a gastroenterology ambulatory surgery center. Performance areas associated with the operating budget include productivity, cost control, staffing, quality of care, innovation, and long-range planning. Major budget constraints include a gastroenterologist, a CRNA, nurse manager, staff salary, education, supplies, and overhead expenditure. Staffing and costs along with overhead, education, and supplies exceeded our budget by close to $50,000. Now, a $1 million budget at gastroenterology clinics allows for cost containment but can lead to lost revenue and staff dissatisfaction. We certainly don't want that. However, the most important thing that we realized that was in order to conduct 70 to 100 GI cases per week and stay within the budget, we had to explore other alternatives. Such cost-contained alternatives would include the usage of one CRNA included, or are we going to use two? In this study, it will be guided by DNP Essentials 2, 4, and 5. Keywords for this particular study include performance budget, gastroenterology ambulatory surgery center, cost containment, productivity, quality of care. The performance budget is based on a GI center located in Mississippi. The center is composed of a gastroenterology clinic and a gastroenterology ambulatory surgery clinic. The budget for the ambulatory surgery center only will be included. The initial problem that we are facing with the budget is like $1 million will not cover the salary for a gastroenterologist, two CRNAs, and the rest of the facility. Knowing that we will immediately be in a deficit of $50,000, we started to look at other alternatives. We want to have enough money to attract a qualified gastroenterologist, so we raised our budget to $1.5 million per year. As with most facilities, the doctors and anesthetists fall outside the purview of the nursing realm with this performance budget. They will be included as they are a large part of the operation of the clinic. The gastroenterology ambulatory surgery clinic will be profitable when conducting 75 to 100 cases per day, or perhaps anywhere from like 15 to 17 cases a day. Our selected performance area will be to increase productivity, cost control, and quality of care to our patients. With an operating budget of $1.5 million per year, we will demonstrate the percentages that will be used to improve each of our three target performance areas. There has also been a decrease in reimbursement for Centers for Medicare and Medicaid services. CPT codes for 2018 and 2017 have been reduced for GI upper and colonoscopy, but if you do a double, like for colonoscopy and EGD, it has remained the same. The code changes and the billable hours that were 5 base units have now been changed to a range of 3 to 6 base units. For some rural facilities, this has been an impact of a loss of $32,000 in anesthesia revenue alone. In description of the staff and their function, the time of business, our clinic is going to be open from 6 a.m. to 4 p.m. Monday through Friday. The GI doctor and CRNAs have been contracts, so they will not be receiving any overtime. The other staff will work 40 hours. Anything over 40 hours will be time and a half. We're also going to give holidays with paid for New Year's Day, Martin Luther King, Memorial Day, Independence Day, Labor Day, Columbus Day, Veterans Day, Thanksgiving Day, day after Thanksgiving Day, and Christmas Day. Any other paid days off will be at discretion of the management team and will be decided at that time. Our staff will include a gastroenterologist, certified nurse anesthetist. We're going to have 2 nurse managers, RN, and LPN. We're also going to have a scope tech and a GI tech. Those 2 roles can be used interchangeably. Also, we're going to have an office manager, medical office assistant checkout, and a secretary. Now we will talk about the flow of the patient through the ambulatory surgery center. Now, how will we take care of the patient once they present to the facility? First of all, 7 days before the procedure, we're going to call the patient, remind them that they're supposed to come in. And this will be done by MAO, a medical office assistant. They're going to check in at the front desk. LPN will check the patient for the procedure. After that, RN will do the anesthesia evaluation of the patient. If the patient has not been seen within 30 days, the GI doctor will do a history and physical. Now, after that, the patient will meet with the CRNA. Then after the CRNA does his or her assessment, they're going to be taken back to the GI room where the procedure is performed. After the procedure is completed, the patient will be taken to the PACU by the CRNA, and the nurse anesthetist will give a report to the RN and LPN, and the patient will then be transferred, will be in the PACU, or post-anesthesia care unit. The patient will be kept in PACU for a minimum of 20 minutes, and the vital signs will be taken every 5 minutes. If the patient meets the discharge criteria, they will be discharged with the RN signature. If discharge criteria is not met, the CRNA MD will be informed, and necessary steps will be followed. Patient then will be proceed if they follow qualification to go to checkout. Patient will proceed to the checkout desk where MAO checkout personnel will process the patient and ensure that all forms have annotated, all questions have been answered, all follow-up appointments have been made with satisfaction of the patient. They will also ensure that the patient satisfaction form has been completed at this time. The patient then will be transferred to their vehicle via wheelchair. Now, the percentages that we have allocated for the operating budget resource to performance area, we want to increase our productivity by 25%, cost control by 25%, staffing by 20%, and improve staff satisfaction by 10%. Also, improve patient satisfaction by 10%, quality of care improvement by 5%, innovation and long-range planning will be 5%. Okay, now what exactly is a performance budget? A performance budget is a budget that reflects the input of resources and the output of service for each unit of organization. Another definition of performance budget, it allows the organization to define the various elements of performance that are important. It can then assess managers and departments based on their accomplishment and in terms of those elements. A performance budget can be considered a blueprint of the goals of an organization and the way it will try to achieve those goals. And we also want to increase productivity. The key to any corporation's survival is to increase the revenue of the institution while at the same time decrease the cost of obtaining such revenues. This is hopefully done while maintaining, if not improving, the product which is being sold, bartered, or produced. Productivity is a measure of efficiency of a person completing a task. Two ways in which we will measure productivity are the number of cases being performed and the number of cases being canceled. At the current time, we're performing at least 15 cases a day. We want to get to each at least 17 cases a day. Our goal is definitely 17 cases a day to increase revenue. The average cost for a colonoscopy is about $1,400, and the high end is about $1,700, and the low end for colonoscopy is about $1,000. If you can increase 2 cases per day without going to overtime, we can add close to like $2,798 per day, or close to $14,000 a week we can earn extra. The yearly increase is almost $800,000. This can be accomplished by doing an initial interview with the interview where a patient can change into a gown and then interview will proceed. When we're interviewing the patient, we're also going to start the IV. This will save 10 minutes per patient or 150 minutes per day, thus allowing you to perform 2 to 3 more cases per day. The second measurement of this goal is to decrease our patient cancellation rate by 25%. As of now, we're averaging 4 cancellations a week. These are some of the reasons for we get canceled patients. Patients sometimes calling in and canceling before being scheduled for a procedure. Patient not calling in and canceling after procedure scheduled for a procedure. Patient being canceled before because of NPO violations. Sometimes patients cancel the day before the procedure for taking blood thinners the day of procedure. The requested clearance is not on chart, like cardiac, pulmonary, neuro is not on chart. Or the patient does not meet the criteria for the ambulatory surgery center. Or sometimes we're not able to start the IV on the patient. The second performance area we will look at is cost control. Cost control must be maintained to remain a viable institution. A definition of cost control is the practice of identifying and reducing business expenses to increase profit, and it starts with the budgeting process. As a DNP, we need to be mindful of controllable costs with the ASC that can be controlled through the department. Controllable costs are costs that can be influenced or regulated by the manager or held responsible for it. For example, direct materials, direct labor, and certain factory overcosts are controlled by the production manager. Other two methods of measurement in this area would be staff salary management and case revenue. One of the problems that we're facing is the salary of a gastroenterologist. We're currently budgeting for $320,000 for his salary. This may be not enough to attract a qualified physician. The average salary in 2018 for a board-certified gastroenterologist was $487,000 without any costs or without any additional benefits. The high end for a GI doctor is like $725,000, and the low end for a GI doctor is $355,000 with no additional benefit. Knowing that our initial salary is very low, we raised our starting salary for the GI doctor for $450,000 per year. This will keep us within a yearly budget while allowing us to attract a qualified GI doctor. We still have some money left in the budget to increase the offer if necessary, knowing that we are lower than the average starting salary. There is still money left to budget for his replacement during illnesses or any type of absences. The second point is that we have a 2-room operating room. Should we staff with 2 CRNAs or should we staff with 1 CRNA? We could also use 1 CRNA to increase the budget for the GI doctor. However, 2 CRNA will give us the flexibility and staffing. The second CRNA can be used for a backup for emergency procedure or any type of problems that arise. The second CRNA could also help with the flow and keep the patients going or help with a difficult IV. Another key point with salary management is to monitor overtime pay and PRN pay for part-time personnel. The second measurement in this area is to ensure that patients being scheduled are having their procedure being performed. We want to monitor all cancellations and try to have a 25% decrease in this area with an average cancellation rate of 4 per week. We will decrease this by 1 to 3 patients per week. We will accomplish this task in the following manner. If they are coming in for a procedure, if not, would they like to be rescheduled? Ensure that all requested clearances have been performed and are on the chart. Ensure the patient meets the Ambulatory Surgery Center criteria and not have had a difficult problem with obtaining IV access in the recent past. Call the patient a day prior to the procedure to verify that they are coming in for their procedure. Remind them of the NPO status as well as to take their prep in the correct manner. They need to also stop their blood thinners or take their per PO MD orders. By implementing these new guidelines, we can see a decrease in patient cancellation by 1 to 2 patients per week. This would be an increase of at least like $1,200 per week or at $72,000 per year if we have only 1 less cancellation per week. This would double to $145,000 plus per year if we have 2 fewer cancellations per week. In performance area quality care, the third performance area is quality care. The Institute of Medicine defines healthcare quality as the degree to which healthcare service for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. A second definition of quality healthcare is as stated. Quality in healthcare means providing the care the patient needs when the patient needs in an affordable, safe, effective manner. Our 2 measurements of quality care are 40% decrease in adverse event in the Ambulatory Surgery Center. Some of these events are listed like we want to decrease medication errors by 10%, patient falls in the pre and post area by 5%, spasm in the operating room by 10%, intravenous IV infiltration by 5%. We want to patients being sent to the emergency room, we want a 10% decrease. The second measurement of quality care would be a 25% increase in positive patient satisfaction report given during our exit interview. This will be evident by 90% satisfaction of all patients having procedure at the Ambulatory Surgery Center. And looking at the DNP essentials, The performance goal for the Gastroenterology Ambulatory Surgery Center is to conduct 70 to 100 GI cases per week and stay within our yearly budget set forth each year by the executive team, which is $1.5 million per year. Key performance areas include productivity, cost control, staffing, and quality care. And utilizing DNP is essential to organization and system leadership for quality improvement. We must increase productivity and decrease weekly cancellation. This can be accomplished by call all patients 1 week ahead of procedure, review health and history, ask about patient blood thinners, discuss any recent surgeries, ask about cardiac history, explore medical clearance. This includes cardiac, pulmonary, neuro. Call patient 24 hours before procedure to discuss NPO status. Discuss with patient any history of difficult intravenous placement or anesthesia. This patient procedure may need to be done in the hospital if they're having a lot of problems. The DNP calling the patient a week ahead of procedure and reviewing health information will reduce cancellation by 25%. This will help the Ambulatory Surgery Center to reach our goal of 70 to 100 patients per week. And looking at the DNP Essentials continuum and utilize DNP Essential for the information system technology and patient care technology for improvement for healthcare, the DNP nurse anesthetists could utilize telemedicine to do preoperative anesthesia assessment. This would certainly save time, avoid patients who do not meet criteria for ambulatory surgery center. Such patients could be referred for additional tests and not waste ASC time. If preoperative evaluations are done ahead of time, we may be able to exceed our goal of 17 cases a day, which could increase productivity while maintaining cost control. And utilizing DNP Essential 7, clinical prevention and population of health by improving the nation's health, the DNP could help lower adverse effects at the ambulatory surgery center by 25%. This can be done by providing medication classes to nursing staff to decrease medication error. Offer all patients wheelchair assistance before and after each procedure. Establishing a policy requiring all patients that receive anesthesia must be transferred to his or her vehicle in a wheelchair. Help CRNAs provide anesthesia in a safe, unrushed manner to help decrease spasms, laryngeal spasm, or complication. Have all nurses receive an IV class and certification to decrease IV infiltration. Make sure all selected patients are suitable for ambulatory surgery center procedure to help decrease emergency visit. And utilizing DNP Essential 8, advanced nursing practice could reevaluate and see if the gastroenterology ambulatory center has been effective in reaching the goal of increased productivity, cost control, and quality of care. Did the center do 70 to 100 cases a day? Did we stay within our yearly budget of $1.5 million per year? Did our patient give us a positive rating during our exit interview? Overall, we did exceed expectation. We were under the budget by $216,000. And utilization of performance budget is an effective management tool of the Gastroenterology Ambulatory Surgery Center being managed by the DNP trained leadership. This is one of the many effective tools available to a highly successful proper organization. One can direct the necessary resources towards a problem that is crucial or achieved within the organization. The ability to change in any direction to increase in one area or decrease in one area once the effects of budget has been implemented is a valuable tool to any DNP. And here are some charts that we have. We have the percentage allocation to performance areas. We have a chart for allocation of operating budget to performance area, and our highest person being paid is, of course, is our gastroenterologist, $450,000, followed by our CRNAs and our nurse managers. And here's our references. Thanks, guys. This concludes our Gastroenterology Ambulatory Surgery Clinic performance budget created by Toney Banks and Patricia Tharp. Thank you.